Alterations in elimination, disorders of the lower gastrointestinal tract. The lower GI tract includes the small and large intestines. One of the first things we can see, which is a disorder, is constipation. These clients have stools that are dry, compact, difficult, and possibly painful to pass. They may have fewer than 3 per week for several weeks, although we need to look at the stool itself. Is it dry? Is it hard? Is it compact? Or is it soft formed? Because some clients only have 1 bowel movement a week, and for them that is perfectly normal. We may see changes with peristalsis. So we have abdominal distension or gastrocolic reflux. They may have stool retention. This can also be due to insufficient dietary fiber, insufficient water, or an impaired GI mobility, in addition to systemic disorders. Chronic constipation causes include neurological issues, a partial or complete blockage, muscular disorders, and hormonal conditions. These clients have infrequent bowel movements, distended abdomen, pain. They may also have a liquid stool that actually seeps around a stool mass. We diagnose with examination, x-rays, barium enema, and anorectal motility studies. We need to treat the cause. So we may administer enemas such as laxatives, stool softeners, or change the diet, such as legumes, fresh fruits and vegetables, wheat bran, seeds, and nuts. So some of our laxatives or stool softeners are going to facilitate bowel movements or remove toxic substances from the body. They can also help prepare for colon procedure, diagnostic procedure or surgery. This may include like lactulose, which also would reduce ammonia absorption, and this is frequently given with liver disease. Contraindications, we need to be very cautious in using laxatives or stool softeners with an acute surgical abdomen, appendicitis symptoms, a fecal impaction, an obstruction, or undiagnosed abdominal pain. It can cause impaction, gas formation, bloating, electrolyte imbalances, nutrient malabsorption because it's moving foods through the GI tract faster. It also can decrease the absorption of many drugs because it is moving things through faster. These drugs can include bulk-forming laxatives that increase water absorption and increase the total volume of the intestinal contents, such as our psyllium. Emollient laxatives can lubricate or soften the stool, such as the docusate salts or mineral oil. Hyperosmotic laxatives actually increase the water content of the feces. It can result in distension, increased peristalsis, and evacuation. This includes some of your glycerin or polyethylene glycol. Your saline laxatives increase osmotic pressure and draw water into the colon. It will produce a watery stool. These would be like your magnesium salts. And stimulant laxatives induce intestinal peristalsis. This would include your bisacodyl or your senna. So question, true or false? The stomach is part of the lower gastrointestinal system. And we know that's false. That's just the small and large intestine. So again, true or false? Constipation assessment findings indicate infrequent bowel movement and distended abdomen. And we know this is true. So diarrhea. Diarrhea can be acute or chronic. It's basically a frequent stool, more than 3 a day, and it's liquid or semi-liquid. We may have increased peristalsis, dehydration, electrolyte imbalances, and vitamin deficiencies. It can be caused by infections, the diet, intestinal disease, medication, and formula that's used in tube feedings. These clients may have frequent liquid or really soft stools, hyperactive bowel sounds, and because that stool is so watery and so liquid, we can have a lot of skin irritation and impairment. We diagnose with stool cultures. We can do the ova and parasite analysis, hemoccult testing, proctosigmoidoscopy, colonoscopy, or endoscopy. Treatment will be dependent on duration. We can use medication and probiotics, fluid and electrolyte replacement, dietary adjustments, and depending on the length of time, may require our total parenteral nutrition. So one of the main medications would be our antidiarrheals. It is contraindicated with intestinal obstruction and colitis. It can cause increased bleeding time, constipation, urinary retention, drowsiness, bradycardia, hypotension, nausea, vomiting, and respiratory depression. It does increase or decrease the absorption of many drugs. So again, making sure that you are checking your drug book. These drugs can include your adsorbents, such as bismuth subsalicylate, your anticholinergics, such as your belladonna alkaloid combinations, your opiates, such as your diphenoxylate with atropine or loperamide, and your probiotics, such as your lactobacillus. So true or false once again. A patient with diarrhea has hypoactive bowel sounds on auscultation of the abdomen. This is false. They're going to have hyperactive bowel sounds. Irritable bowel syndrome is also known as a spastic bowel. It is a functional motility disorder, so we have a cluster of symptoms with no known disease process. The client has a fluctuating intestinal motility that intensifies with stress. It does occur more often in men or women and younger adults. These clients may have chronic constipation, diarrhea, no blood, stable weight, abdominal pain, bloating, and flatus. X-rays and endoscopic tests may be used to diagnose. We treat it with a high-fiber diet, medications, anticholinergics, and antidiarrheals. IBS-specific drugs with diarrhea may include your allosetron, your rifaximin, and eluxidoline. IBS medications with constipation may include your lubiprostone and linaclotide. Adverse effects with your allosetron would be ischemic colitis, with your lubiprostone, nausea, diarrhea, abdominal pain, and flatulence. There are contraindications with the lubiprostone. Do not give with the GI obstruction or in children younger than 17. And make sure that you encourage elimination of alcohol and smoking and stress management, as these can have an effect on IBS. Another irritable bowel disease is Crohn's disease. This is our regional enteritis. So we have a chronic digestive disorder with systemic manifestations. They may have arthritis, skin lesions, eye inflammation, and liver and gallbladder disorders. It can occur anywhere in the GI tract, but primarily in the terminal portion of the ileum. These clients have an inflammation in the submucosal layer. The affected areas can cause hyperemia, edema, ulcerations, and fistula development. We may see genetic predisposition, smokers, Caucasian with European or Jewish history as being more prone to Crohn's disease. These clients will have bilateral lower quadrant distension, tenderness, chronic diarrhea, fever, and growth failure. We diagnose with a stool analysis, white blood cell count, erythrocyte sedimentation rate, or your ESR, because it will be elevated, barium enema, endoscopic examination, biopsy, upper GI series with a small bowel follow-through. Treatment will be supportive. Make sure we're making appropriate changes to their diet. They may get TPN, have IV therapy, whole blood, different medications that would include your antidiarrheals and your antiperistaltics, your 5 ASAs, corticosteroids, and immune modulators. Surgically, this is reserved for clients that have complications such as obstruction, perforation, fistulas, short bowel syndrome, intestinal transplant may be required, and ileostomy. 75% of these clients will require surgery within 20 years of symptom onset. 90% require surgery within 30 years. Nurses need to monitor for complications and fluid and nutrition replacement. Ulcerative colitis is a chronic inflammation of the colon and rectum. We see immune-related disorders, but there's also a genetic predisposition, infection, and allergies. It is most common in our young to middle-aged adults. We may see a toxic megacolon that can develop where the colon dilates and becomes atonic. In other words, it loses its tone, and it can lead to emergent problems. These clients have an abrupt onset, diarrhea, blood, pain, pus, and mucus. They may also have dehydration, excuse me, anorexia, a sudden bowel urge where they have 10 to 20 stools a day. They can go through exacerbations and remissions. We diagnose with barium enema, endoscopic examinations, proctosigmoidoscopy, biopsies. The goal of treatment is to achieve remission. We may need to alter their diet, give TPN with lipids, surgical procedures, blood transfusions, drug and fluid therapy. Nurses should monitor for stools and complications and provide client teaching for medications. In their diet, they need to increase their calories and their nutritional content. So the acute abdominal inflammatory disorders, the biggest one is going to be appendicitis, and that's going to be inflammation of a narrow blind protrusion that's located at the tip of the cecum. It's most common in adolescents and young adults. This inflammation occurs when the opening becomes narrow or obstructed, and we see a bacterial infection. These clients have pain that begins around the umbilicus, and then it moves to the right lower quadrant, or what we call McBurney's point. They have rebound tenderness, which is where you push on the stomach when you're palpating and you abruptly release and it causes pain. They have the positive Rovsing sign, which is pain that is felt in the right lower quadrant when you palpate the left lower quadrant. Other classic symptoms include a low-grade fever, an elevated white blood cell count, and usually that white blood cell count is not elevated really high unless there's additional issues going on. Nausea, vomiting may also be present. Constipation. Rupture can occur within 24 hours of pain onset if it's not treated, and this can cause peritonitis or an abscess. We diagnose by looking at our blood counts, doing an abdominal ultrasound or a CT scan. Antibiotics may be required, IV fluids of course, and they have to have an appendectomy. Initially, we withhold analgesics because we don't want to mask any pain if that appendix ruptures. So nurses need to quickly prepare these clients for surgery, and then postoperatively, they should, of course, avoid that heavy lifting or straining for months following surgery, although general activities can resume sooner. If the abdomen is palpated, the nurse should always cease palpation if pain is felt. Peritonitis is inflammation of the peritoneum. This is basically going to be the lining of the abdominal cavity. This can happen from a perforated peptic ulcer, a perforated bowel, a ruptured appendix, inflammatory bowel disease, ruptured ectopic pregnancy, infection from peritoneal dialysis, and it's caused by bacteria. These clients have a lack of bowel motility following hyperactivity. They may have a paralytic ileus, in other words, the peristalsis has now stopped. They may have rapid respirations, and they can progress to hypovolemic shock. We look at their white blood cell count, x-rays, CT scans, ultrasounds. We can do a culture and sensitivity of peritoneal fluid. They may require an NG tube, IV fluids, electrolytes, antibiotics, antiemetics, and surgery to close that perforation. We need to monitor their status, provide emotional support, and postoperative care. One of the classic signs of peritonitis is they have what we call that board-like abdomen when you attempt to palpate. In other words, it's very rigid, it's very hard. Intestinal obstruction is a blockage that interferes with normal progression of intestinal contents. It can be functional or mechanical, which is more common in the, and obstruction is more common in the small bowel or the small intestine. It can be fatal if it's not treated rapidly. So with mechanical, adynamic, complete or partial obstruction, cause can be from a tumor, adhesions, which is scar tissue in the abdomen or basically anywhere, hernias, maybe from a volvulus, which is a kinking of the bowel, or intussusception, which is where the bowel kind of telescopes on itself, or fecal impaction. These clients have distension of the abdomen, emesis with bile or fecal contents because things are not moving through the digestive tract, cramps, and absent bowel sounds. Perforation symptoms, that's that sudden, sustained abdominal pain, abdominal distension, fever, that board-like abdomen. We diagnose with x-rays, serum electrolytes, metabolic alkalosis may be present, white blood cell count will be drawn, and a hematocrit level. We manage it with IV fluids, electrolytes, antibiotics. We may just decompress the intestine by inserting the NG tube. We can also do surgery, and these clients may require an ostomy placement depending on the significance of the blockage. Our nurses need to observe vomitus, monitor the client's status, and report urinary output below 50 mLs per hour with intestinal obstruction, because this can indicate possible hypovolemic shock in these clients. Diverticulosis and diverticulitis are little herniations or pouches in the mucosa of the GI tract, usually in the large intestine. Diverticulosis is basically asymptomatic diverticula. Diverticulitis is where we have an inflammation going on. It can be caused from a low fiber intake, congenital predisposition. We have inflammation when the diverticula become obstructed. They can also form abscesses or fistulas. Other factors that can lead to diverticula are obesity, a lack of exercise, smoking, and some medications. These clients may have alternating constipation or diarrhea. They may have rectal bleeding, causing stools to be a maroon color or appear like a currant jelly, which is going to be kind of a dark maroon. We diagnose with stool specimens, CT scans, barium enemas, and colonoscopy. These clients need to avoid food that contains seeds. They need to be on a high fiber diet, IV fluids, antibiotics. They may require a colectomy or a colostomy if their disease process is severe enough. Client education should be provided on their diet. They should avoid constipation and laxatives, and we need to encourage fluid in these clients. And lastly, colon and rectal cancer. This can develop anywhere in the lower GI tract. Colorectal cancer is the third most common cancer in the United States. It can start from a benign adenoma. We may see an adenocarcinoma. Polyps are one of the precursors to colon cancer. Genetics, they may have ulcerative colitis. Their lifestyle and environment can also be factors. If they have chronic bowel inflammation, they're on a long-term low fiber diet or a high fat diet, this can also lead to colon cancer. These clients will have a change in their bowel habits. They may have frank blood or occult blood in their stool, a distended abdomen, and abdominal discomfort. We diagnose by looking at a CBC, a barium enema, colonoscopy, genetic testing, a CEA test, and biopsies. We need to examine any polyps, keep an eye on them if they have been diagnosed, do x-rays and scopes such as your endoscopy or colonoscopy. With colorectal cancer, surgery, radiation therapy, chemotherapy, colectomy, a segmental resection, or an abdominoperineal resection may be required. These clients definitely require supportive care and postoperative care.